Well, that's coming up. Good evening, everyone. My name is Feuer. I'll say the very nice introduction. And I'm going to start us off with a little bit of an introduction on what ACOs are. This is a very challenging task. And the reason why it's challenging is because ACOs, like many aspects of healthcare reform, are very poorly defined and very transitory. We don't really know what they're going to look like in the future, and it's really hard to tell what the status is right now. And I also know that talking about the basics of ACOs is very challenging because I did some work at the Massachusetts Medical Society while they were putting together their ACO how-to guide. Putting together this guide required a team of consultants and specialists, 3 months, about 7 different drafts, hordes of emails, and lots of hair pulling to put together the final product. And that final product is about 70 pages long. I have 15 slides. So there's a caveat for you. I know that a lot of you are involved in startups, so with that in mind, my talk is going to center around the needs of an ACO. I'm going to tell you what they are, what motivates them, where they are, and some of the challenges that ACOs are facing. What is an ACO? An ACO, or Accountable Care Organization, is a group of doctors, hospitals, specialists, care providers from various disciplines who work together to provide the full continuum of care for a patient population. The ACO is accountable for the cost and quality of providing care for that population, hence the phrase Accountable Care Organization. The phrase was first used by Dr. Elliot Fisher in 2006. He defined an ACO as having 3 key attributes: organized care, that's the healthcare providers from different disciplines work together to provide that care. Payment reform. Now, traditionally, payment to healthcare providers was under what's called fee-for-service, where every single service would be reimbursed. Under new payment models, we're trying to incentivize good, cost-effective care. And then the third key attribute is performance measurement. So ACOs are tied to a number of metrics that measure patient satisfaction, health outcomes, and profit measurements. And those metrics are reported to the payer and maybe eventually to the public. So the key attributes, at the center you have the ACO, which is the group of providers in different disciplines who work together to provide that full continuum of care. There's the payer, or the health insurer, who provides payment to the ACO under a new value-based payment model. And then the outcome, the performance measurement of the ACO, is reported back to the payer. There are 2 types of ACO contracts: public contracts and private contracts. For now, a public contract means a contract through Medicare. And Medicare has 2 big ACO programs: the Pioneer ACO and the Medicare Shared Savings Program. A private contract means an arrangement through a private payer. The big one in Massachusetts is Blue Cross Blue Shield, which has the alternative quality contract. That's the primary payment contract that they have with ACOs. And then Cigna, Harvard Pilgrim, and Health Plan are also working on value-based payment models. Now I'm going to talk about what motivates ACOs, because I think it's important to understand how the incentives work on these new payment models to understand what incentivizes the behavior of the ACO. So to that end, if you'll bear with me, I'm going to talk a little bit about the basics of payment. Most new payment models work in the same way. There's 2 parts: cost part and quality part. The way the cost part works is there's a global budget that's set for the ACO based on historical cost. What this means is they look at how much it costs to take care of the patient population under the fee-for-service back last year, and they use that total cost to set a budget for how much it's going to cost for the upcoming year. That's the global budget. If the total cost of providing patient care in that year comes in less than the global budget, the healthcare provider gets a bonus. If it comes in over budget, the healthcare provider might have a financial penalty depending on the contract. That's the reason why some of these new payment contracts are called risk contracts, because the healthcare provider may have some financial risk. Now, the cost portion of this payment contract is tied into the quality portion. These are predefined metrics that measure patient health, care processes, and patient satisfaction. The better an ACO does on these metrics, the bigger the bonus it gets if it underspends the budget. So in other words, if the cost of care comes in under budget and the healthcare provider provides good quality care, they get a big bonus. Come in under budget, cut costs, but provide bad care, small bonus. The takeaway is that ACOs have an incentive to both reduce the cost of patient care while also maintaining or improving the quality of patient care. Where are ACOs? This map is a little bit misleading. This map is not showing just ACOs, and it's not showing all ACOs. But what it is showing you is where in Massachusetts clinical innovation is happening. And what you'll notice is that, maybe not surprisingly, there's a big cluster of clinical innovation right around the Boston area. There's a smattering of innovation in the greater Boston area, and there's not too much else except for this other big cluster right around Springfield. I don't really know why that is. Maybe someone in the audience knows why there's so much innovation happening around Springfield. Did anyone?
Probably predominantly because of Bay State. It's a very large and very successful provider in that market. There's a lot of patient-centered medical home initiatives underway, a variety of ACO-related activities.
Okay, and then finally, I'm going to tell you about some of the challenges that ACOs face. So as I mentioned, ACOs need to continue reducing the cost of patient care if they want to keep getting those bonuses. There are a few different ways that this has been done in the past. For example, reducing inpatient visits. Hospital visits and hospital stays are very expensive. If you can prevent a hospital stay, there's an opportunity there to save costs on patient care. Reducing the number of tests or procedures that are performed. We perform a lot of unnecessary testing in the country. So we can reduce those unnecessary tests. There's a way to reduce costs. Reducing the cost of specialty care. Some of the early analysis done on the alternative quality contract with Cost of Shield ACO arrangements found that providers were reducing costs by sending patients to cheaper specialists. Another option is to bring the specialists in-house, bring them into the ACO, where the ACO has control over the cost of that specialty care. ACOs also want to improve patient health outcomes. Why do they want to do this? Well, first of all, health outcomes are one of those quality metrics that the bonus is tied to. Also, improving health outcomes will reduce costs because healthy patients are cheaper patients. So some of the ways this can be done. Patient engagement. There's a reason why it's phrase all over the place. It's because patients that are engaged and actively involved in their care tend to follow their care management plans better, and they do better in terms of their health. Wellness programs. These are programs that are designed to keep you healthy. Maybe you'll see them at your healthcare provider or in your place of work or in community health centers. Things like free yoga classes or incentives for taking the stairs instead of the elevator. And also preventative care. It's not a surprise. We've known this for years. Preventative care is cheaper than sick care. We can keep people from developing chronic diseases, keep them out of the hospital, keep them from developing illness. It's cheaper than treating them illness. So that's part of the reason why we're seeing a big push towards preventative care these days. For example, a lot of health insurance plans are removing co-pays for physical exams. Finally, regulatory compliance. There's a wave of new regulations that ACOs need to follow, and all healthcare providers, such as the ICD-10 transition. ICD-10 is the code index that's used for diagnosis, moving from ICD-9 to 10, and there are a lot more codes in ICD-10. This means there's going to be a lot of need for IT and for training. The HIPAA Omnibus Bill, which actually comes into effect on Monday, and it has a number of changes such as updates to notice of practices that all providers need to make. There are new definitions for business associates and contracting required along with that. And patient privileges. For example, patients will now be able to request that the information permission to visit, not go to their health insurance. And meaningful use. Meaningful use is a national program that's designed to encourage electronic use of medical health data. Stage 1 involves moving from paper medical records to electronic health records. And then stage 2, for which the incentive payment starts on January 1st, involves the exchange of health data and also the creation of patient goods.
Thank you.
And an accreditation, significant.
For 2015, and you won't be able to have a medical license in the state.
That's right. Correct.
That's a little scarier one.
Is that just Massachusetts?
Just Massachusetts, but I'm aware of. Do you know of any other states?
I'm not aware of any other states. Massachusetts is very aggressive in this. They also have a lot of incentives to get providers on. A lot of money, a lot of help. The organization that's responsible for the highway, one of the organizations, which is the Mass eHealth Institute, I'll go into them in a little bit in a second, is responsible for the dissemination of grants and subsidies and training through regional training centers to get not only small primary care practices, individual physician practices, but also behavioral health providers, home health providers, small rural access hospitals. And I mean small, I mean like 10 beds. To get them as much help as they need to get digitized. And the technology they need to have a compliant EMR does not have to be an expensive application. In many cases, it can be a very simple application that meets the basic criteria required for meaningful use. So these aren't, multi-million-dollar applications for small providers. There are many of them that are free. There was, I don't know if they still are, but Practice Fusion is an EMR that you can get online. It's certified. It's meaningfully use compliant. It's a terrific EMR. It's open source. But you got to implement it, and you got to use it meaningfully before you get the money from the government. Yes?
It seems like there's obvious benefits for kind of a move towards the EMR, but what would be some of the concerns for me as a patient of a movement towards, or industry moving towards the EMR?
I think the concerns that a number of patient advocates have expressed are, one, that the current state or the current form factor, if you will, of a laptop computer that I have to go like this to and look at and then talk to you about is disrupting and distracting the provider-patient relationship. That there is this technical kind of intruder in the room, the distractor in the room, and that it takes away from, lack of a better term, face time. And I think that's a soluble problem. I think technologies will improve on it. The other issue that people are raising with EMRs is privacy. But my response to that is, I have a lot more confidence in the privacy of my medical information today than I did when I went to a clinic and they couldn't find my record. I mean, the alternative isn't perfection. The alternative is what we had before. And the risk of my getting tests that I don't need or